Thank you, everybody, for tuning in to me and Dr. Yin's presentation. Today, we are going to be hearing a little bit about deep brain stimulation and how it's used for the treatment of Parkinson's disease. So without further ado, here is Dr. Yin.
Okay, let's start. Hi, good morning, everyone. The first, thank you for joining us. Today I would like to talk about the deep brain stimulation (DBS) for treatment of the Parkinson's disease. Just more. Oh, I can move forward with the slide. Okay, yeah. So do you guys know who is this? So this is President Bush. He attended the AANS meeting in Chicago in 2016. So I took this picture while he was answering questions. Let me see, we can go here. Okay, yeah. A question for you guys. So how many people here know about the DBS? Good. How many people have seen DBS surgery? No answer? Okay, yeah. So DBS is a surgical and medical treatment for different disease. So DBS is a teamwork. So it involves not only neurosurgeon, but also neurologist and psychiatrist. So DBS system function as a brain pacemaker. So DBS is appealing because it provides a targeted, adjustable, non-destructive, and reversible means of the modulation the pathological states of the brain circuits. Therefore, so improving the brain function for treatment of the different disease. Okay. Oh, it's go too fast. So. Oh, it's okay. Yeah. So DBS has become a highly effective treatment options for movement disorders, and the new indications for DBS in the treatment of other neurological and psychiatric disorders are emerging and continue to evolve. So you can see here, DBS is approved by FDA for treatment of essential tremor in 1997, Parkinson's disease in 2002, and dystonia in 2003, OCD, obsessive compulsive disorder in 2009, and the focal epilepsy in 2018. So using DBS to treat the Tourette, depression, addiction, and Alzheimer's are under investigation. Yeah. But recently, so we have the new indication for DBS. So that's very exciting. We can use DBS to target the dentate nucleus to treat the patient with the motor deficit after ischemic stroke. So how does DBS work? The exact mechanism of action of the DBS is unknown. However, it's known that DBS changes the message in the brain. So DBS may play roles in information leaching in the target nucleus, depolarization blockades, synaptic inhibition, and the network modulation. So chronic DBS stimulation entrains irregular neuronal firing pattern and desynchronized pathological hypersynchronization with the sensory motor circuits for improvement of the patient's symptoms. So let's talk about the Parkinson's disease briefly. So Parkinson's disease is the most common neurodegenerative disease disorder. It is the most common motor-related disorder in the world. So it affects nearly 1% of the population over 60 years and 4% of the population over the 80 years old. So the rate of the diagnosis of the Parkinson's disease is expected to rise as the life expectancy of the population in the world increase. So over 1 million people have Parkinson's disease in United States. So moreover, the physician diagnoses 60,000 new cases each year. So the average age of onset of the Parkinson's disease is about the 60 years old. However, so 10% of the case are diagnosed as early onset between the age of 20 and the 50. Yeah. So the men are more likely to suffer from the Parkinson's disease than the women. It's reported that this may indicate protective property of the estrogen. So the traditional understanding of Parkinson's disease focuses on two principal neurological findings: the loss of the dopaminergic neurons and the presence of Lewy body in the brain. The dopaminergic neurons reside in the midbrain region called the substantia nigra pars compacta. It's here, so like this. It is the primary source of neurotransmitter dopamine for central nervous system. So although dopaminergic neurons account for less than 1% of the total number of neurons in the brain, they play an important role in the control of the multiple brain functions, including voluntary movement and a broad array of the behavior process like the mood, reward, addiction, and stress. So this is a schematic diagram of the nuclear and the pathway of the basal ganglia. So this is the STN here. So this is the GPI here. So STN is an important nucleus in the functional organization of the basal ganglia. So the nigrostriatal pathway is dopaminergic. So in Parkinson's disease, so dopamine deficiency results in increase in neuronal activities in the STN and the GPI with irregular and bursting neuronal firing patterns. So increased synchronization is found among sensory motor networks, which may contribute to the symptoms and the sign of the Parkinson's disease. So these are motor symptoms of the Parkinson's disease, including blank facial expressing, slow slurred speech. So resting tremor, we also call the pure rolling tremor, rigidity and stiffness, slowness of the movement, a short gait, and the posterior instability and impaired the balance. So these are non-motor symptoms of the Parkinson's disease, so including dementia, mild cognitive impairment, depression, anxiety, so orthostatic hypotension, overreactive bladder, constipation, hyperhidrosis, problem with the sleep, pain can have the pain, and the behavioral problem. So to diagnose the Parkinson's disease, patient need to have at least the 2 of the 3 cardinal Parkinsonism, the rest tremor, rigidity, and bradykinesia. So onset of the symptom is asymmetric. A patient need to have response to levodopa. So in other words, levodopa improve patients' symptoms. We also need to pay attention to the symptoms suggesting other diagnoses, such as dementia with Lewy body, vascular Parkinson's, and Parkinson's plus syndrome. So MSA, multiple symptom atrophy, and the PSP, progressive supranuclear palsy. Wait a sec, let me see. Oh yeah, so yeah, that's the slide I mentioned before. So I scrolled too fast. That's it's let me go here. Yeah. So sometimes patient initially diagnosis with the idiopathic Parkinson's disease, so are later found to have the different diagnosis like this. So this disease do not respond to DBS treatment as most Parkinson's plus syndrome declare themselves by 4 to 5 years. It's suggested to offer DBS to patients with Parkinson's disease at least 4 years after diagnosis. For Parkinson's disease, we can treat the patient with the medication, surgery, so including deep brain stimulation, DBS, and MRI-guided focused ultrasound, salamatomy, rehab, and the palliative care. But currently, we cannot cure the Parkinson's disease. So focused ultrasound salamatomy is mainly for treatment of the tremor. So at the early stage of the Parkinson's disease, medications such as levodopa effectively improve motor symptoms, such as the tremor, rigidity, slowness of the movement, and the shuffling gait, and the posture problem throughout the day. So movements are often controlled with little to no fluctuation in response to each dose of medication. So at the mid stage of the disease, although medication continue to improve the symptoms, the time that each medication dose is effective becomes shorter, often not lasting from one dose to the next. When the benefit of medication wear off between doses, the medication must be increased or taken more often. So at the last stage of the Parkinson's disease, patient's symptoms no longer respond to oral medication. And moreover, patient is no longer a DBS candidate anymore. So here it brought us a question: when should we offer DBS to our patient? So this is the window here of the opportunity to introduce DBS to our patients, but usually the 4 years after diagnosis of the Parkinson's disease. So these are indications for DBS in Parkinson's disease. So not all patients with Parkinson's disease are candidate for treatment with DBS, but many patients will be. So first, so patient needed to have the diagnosis of the idiopathic Parkinson's disease and with more than 4 years of the symptoms. So patient have the motor symptoms, fluctuating motor symptoms that significantly affect the patient's quality of the life. So the levodopa response is predictive of patient response to DBS surgery. So patient with Parkinson's disease, the degree to which a patient is responsive to dopaminergic medication, so particularly levodopa generally predict how responsive motor symptoms will be to DBS. So patients with Parkinson's disease have on time and off time each day. So off time means patients are in their most symptomatic states. On time, so means the patient have responded to their anti-Parkinsonian medication and have achieved their best motor function. So patients need to have at least 30% improvement in UPDRS score after L-DOPA treatment in order to be a candidate for DBS surgery. So in terms of the age for DBS surgery, there is no absolute upper age limit above which DBS treatment should not be offered. So I typically don't exclude the patients from DBS surgery based on age alone. So however, the patients older than 75 years old may tolerate DBS surgery less well, may have more transient post-operative confusion, and the higher risk of the complications from surgery. So these are contraindications for DBS in Parkinson's disease. So including the dementia, untreated depression, infection, coagulopathy, untreated hypertension, untreated diabetes, and the severe cerebral atrophy. So the more brain atrophy patient has, the higher risk of bleeding and the cognitive problem patient may have after surgery. Okay, so let's talk more about the DBS surgery. So to do DBS, we need implant the electrodes into the target and attach it to the pulse generator. So the DBS sends the electrical stimulation to specific parts of the brain. So DBS is a local therapy. So it affects only local circuits and the brain region, unlike medication, which affects the whole body by transmission through the bloodstream. So the idea behind the DBS is to reset the malfunctioning brain circuits by stimulation of the target with the electrical current. So DBS has the three components. Lead, we also call the electrodes, extension wire, and the IPG. So implantable pulse generator, we often call it the battery. So the electrodes is placed into the target of the brain, and then is connected to the battery by extension wire. The extension wire runs from the head down to the side of the neck behind the ear to the battery. So the battery is usually placed in the upper chest under the skin, just below the clavicle. So the battery sending impulse to the specific target nucleus in the brain. So DBS surgery including two parts of the surgery. So stage 1, DBS electrode implantation. Stage 2, placement of the DBS extension wire and IPG, but usually 2 to 3 weeks apart. So this is the stage 1 DBS surgery. So stage 1 surgery, DBS electrode implantation is performed while patient is awake and under the local anesthesia. So stage 1 surgery, including the placement of the head frame for fixation, head CT and MRI for registration and coordinates, surgical planning, a Leksell or shear W frame attachment. Then we make the bar hole. So we do the MER, so macro electrode recording for verification of the target. And then so we insert the DBS electrodes and do more testing. So this is the placement of the Leksell head frame. So this is the head frame. It is attached to the patient's head just before surgery. So this frame served as a base for aiming and hardware implantation, and is also used to secure the patient's head during the surgery. So this is the fiducial box of the CT, also called the localization box. So this is the adapter. So patient's head is placed into the adapter and the fiducial box is placed, then head CT is done. So this is the fiducial box for MRI. Fiducial box are used to make a three-dimensional coordinates of the brain. So this is T1 MRI with contrast. So this MRI is used to see the vascular anatomy, the blood vessel in the region of the cortical entry point along the trajectory and at the target. So T2 MRI is used to see the target. Here you can see, so that's the STN here. Okay, so let me see here. Okay, yeah. So these are software for surgical planning. So we have the Brain Lab from the Germany, also Style Station from the Medtronic in United States. But I use the Brain Lab for my surgical planning. So this is a workflow for surgical planning for targeting and the trajectory with the Brain Lab. So including so load and import imaging into the computer. So localization with the CT. Then so I fuse the CT with the MRI. Then we do the ACPC localization. AC stands for anterior commissure. PC stands for the posterior commissure. The last step is the stereotactic planning for target entry point and the trajectory. So while planning the DBS trajectory, I will make sure so the electrodes does not go through into the ventricle and the sulcus. So why I try to avoid the sulcus, because there are blood vessels in the in the sulcus. Yeah, because if the electrode goes through the sulcus, it may damage the blood vessel, cause the bleeding. Okay, this is the targets of the DBS for treatment of the movement disorders. So we use the STN and the GPI for treatment of the Parkinson disease. We also use the VIM to treat the tremor. So to determine the target, we can use the different methods, so including direct targeting methods. So the target nucleus needed to be directed seen on MRI. Indirect targeting methods, we use the coordinates to determine the targets in reference to the anterior and the posterior commissure. We can also use internal anatomical marker to determine the targets. So again, so what's this? I already showed you. So this is the STN. So this is the red nuclear. So for direct STN targeting, we need to see it on MRI. So STN is a very small structure. We need to target the dorsolateral STN. So it's here. So these are coordinates for indirect STN targeting. So it is the 12 millimeter lateral, 3 millimeter posterior to the MCP, and the 5 millimeter below the MCP. So MCP stands for mid-commissure point. So we can also use the red nuclear as internal anatomical marker to target the STN. So this STN here. So this is the red nucleus. To do so, usually, so I draw a line. So just at the anterior border of the STN, that's this line. Then you draw another line, 3 millimeter lateral to the lateral border of the red nuclear. So that's this line. The cross point, so is the target of the STN. You can see here, you draw a line in here, 3 meter line in here. So that's the target here. Okay. Yeah. So the targeting techniques for DBS, so including the frame-based stereotactic targeting. So we can use the Leksell Frame, CRW, this Leksell Frame, this is the CRW frame, this is the compass frame. We also have the frameless stereotactic technique. So it is the MRI guided targeting. Yeah. So for MRI guided targeting, so DBS is performed with real-time intraoperative MRI to guide and confirm DBS lead placement while patient is under general anesthesia. Okay. Yeah, this is a Leksell frame. So I use Leksell Frame for my DBS surgery. Yeah, this is the DBS surgery with the Leksell Frame. This is the patient position. This is the C-arm. This is the curtain drape. So this is Leksell Frame. I will make the butthole and insert the microelectrodes for MER. so microelectrode recording. So I do MER to find the target. After I found the target, I take out the microelectrodes, insert the DBS electrodes, and do more testing to make sure it works. So this is the implantation of the generator, that is the stage 2 surgery. So the efficacy of the DBS is highly dependent on proper placement of the DBS electrodes. The intraoperative MER, so microelectrode recording, had been used for physiological mapping. So MER allows precise identification of the sensory motor region of the target. So the use of the MER in addition to anatomical targeting proved to be more precise than surgical targeting based solely on anatomical information provided by the MRI. So this is the stage 2 surgery, the placement of the DBS extension wire and the IPG. So the stage 2 surgery is performed 2 to 3 weeks after stage 1 surgery. So the lead extension are tunneled from the head to the upper chest and connect to the IPG. So the battery, the IPG is replaced every 3-5 years. Now we also have rechargeable battery. So after implantation of the DBS electrodes, patient will have the CT to rule out the bleeding and the MRI to confirm the DBS electrodes placement. So this is the post-op imaging showing DBS electrodes in the STN here. You see here, here. So this is the post-op MRI showing DBS electrodes in the GPI. Here, you can see it here. So in terms of DBS for treatment of the Parkinson's disease, so DBS significantly improved the tremor, rigidity, bradykinesia, dyskinesia, motor fluctuation, freeing of the gait if occurring in the off the state. But DBS does not improve the hypophonic speech, dysphagia, macrographia, balance, freeing of the gait occurring on the on time. If a patient have the dementia, depression, psychosis, DBS can make these conditions worse. So the randomized controlled clinical trial have showed that both STN DBS and the GPI DBS improve overall motor functions, increase on time, therefore improve the patient's quality of life. So moreover, so great a reduction of medication is achieved with STN DBS. So you can see here medication reduction is about 30 to 50% as compared to the GPI DBS. Medication reduction is about 10 to 20%. So some clinicians report that up to 10% of all patients treated with bilateral STN DBS are able to stop all medication at least for some period of time. Therefore, STN DBS may be appropriate in selected patients who are unable to tolerate the adequate dose of the anti-Parkinsonian medication. So randomized control clinical trial also showing that DBS therapy is superior to the best medical therapy for improving the motor function and the quality of patient's life. Yeah. So this patient has Parkinson's disease with the tremor. When DBS is off, you can see patient has the tremor. Yeah. It's difficult for her to do the finger to finger test. So when DBS is on, you see, so the tremor just stop. Patient can do better finger to finger test. So I like the DBS very much because it works for our patient, can significantly improve patient quality of life. So patients with Parkinson's disease have tremor. They cannot use their hands to do the daily activities. However, so after DBS treatment, tremor just stops. For example, so this patient is a violinist. He could not play violin because of the tremor. So after DBS electrodes is placed into the target and start stimulation, he is able to play the violin again. So is that amazing? Okay. Yeah. So these are factors for success in DBS treatment. So first, so we need to select the patient properly. In the use of the DBS, appropriate patient selection is a major determination of the successful outcome. Second, so we need to place the DBS electrodes accurately. So the goal is to place the DBS lead so accurately in the center of the sensory motor region of the target nucleus. So equally important is to avoid electrodes placed close to other neighboring nuclear and fiber tracts, because the stimulation of these neighboring nucleus and the fiber tracts will cause adverse effects. The third, a patient needed to have the reasonable expectation regarding the outcome from the DBS treatment. So patient needed to understand that DBS will not cure the disease or not likely alter the disease process. So DBS is to optimize the motor function, therefore improving the patient quality of life. Of course, we also need to do the optimal programming in conjunction with the medication treatment. Yeah, we also need to do long-term management of the disease progression and the troubleshooting of the device issue. So DBS is a great therapy for different orders, including Parkinson's disease, but its surgery, the DBS is not without complications. So the complication is related to DBS procedure, including the hemorrhage, seizure, paralysis, CSF leakage, and the coma. So complications related to the device, including infection, skin erosion, and lead malposition and maculation. So adverse effect related to stimulation, including the paresthesia, disaster, muscle contraction, so on and so forth. But DBS also may make the depression worse, can make the suicidal ideation worse. Yeah. I do see the one had the fellowship at the University of Colorado. I do see the patient before surgery, patient had the suicide ideation, but 6 months after DBS placement, the patient conducted suicide, unfortunately. So the DBS is a great treatment for Parkinson's disease. It actually is the most revolutionary therapy for Parkinson's disease. But we cannot cure the Parkinson's disease with the DBS. So is DBS good enough? So what's the pathway from good to great? But in the future, if possible, we may be able to use the triple therapy to treat the Parkinson's disease, so which include the cell therapy, DBS, and the gene therapy. I hope we can do this in the future. I think that would be great for the patient with the Parkinson's disease. Okay, so let me see here. Yeah. So does DBS, let me go up here. So does DBS affect our practice? It's the big yes. First, so we have the patient population. So a lot of the patient with the Parkinson's disease, sensory tremor, and ischemic stroke. If we have the DBS at the AANS and the inside surgical hospital, so our hospital is viewed as the cutting edge with the high technology. So also DBS technology can attract the patient to our facility, our hospital. I think that's great for our program and our hospital. So the future of the DBS surgery and the functional neurosurgery is so bright, we need to wear the sunglasses. Thank you. Do you have any questions?
All right, at this time, as usual, I will give you the option to unmute yourself, or you can also type any questions in the chat if you have them. But to kick things off, I think I will start with a question. Dr. Yin, I was just curious, is this a procedure that some patients will find uncomfortable during like the implantation process, or is it relatively what's the word I'm looking for? Harmless, I guess. Like, do they feel any pain or anything during the actual implantation process?
Yeah, that's a good question. So actually, patient, because the first in the early morning of the surgery, I need to put the frame onto the head. When I put the frame, patient doesn't feel pain. Okay. But actually, most of the patients said that's the worst part of this procedure. After that, so patient doing fine. Yeah.
I see. Okay, thank you. All right, and it looks like we have a question in the chat box. I'll go ahead and read it. Tom Sullivan was wondering if the Leksell frame clamped on, or is the Leksell frame clamped on or affixed with screws requiring another procedure?
No, we just put the frame on so in the morning, yeah, or early morning, yeah. Okay. After surgery, we will remove the frame. Yeah.
Anybody else out there with a question for Dr. Yin? Right. Well, if there's no more questions, I suppose that concludes this month's Grand Rounds presentation. Thank you, Dr. Yin, for the presentation.
Thank you.
And everybody, make sure you go ahead and follow us on social media. And I hope you have the best day. And we'll see you next month. Bye-bye, everybody.
Bye-bye.